Hello everyone! Welcome to our NEET PG Respiratory Physiology series. Today we tackle a high-yield classic, compliance of the lungs and chest wall. Keep this puzzle in mind as we go. Why do emphysematous lungs feel easy to inflate but recoil poorly, and how does that show up on the pressure-volume curve? By the end, you'll be able to answer that in one clean line and sketch the curve from memory. Here's your roadmap for this session. First, we'll make compliance intuitive, what it really means when lungs are soft versus stiff, and how the chest wall joins the story. Then we'll read the pressure-volume curve like a language, where the slope matters, where the lung is happiest, and what hysteresis actually tells you. We'll connect this to real practice, how we estimate compliance at the bedside, and how ventilator pressures guide us. Finally, we'll map disease patterns, emphysema with high compliance and poor recoil, fibrosis, ARDS, and edema with low compliance, plus chest wall conditions that shift the whole system. Exam alert as you watch. Whenever you see a PV curve, think slope. Steeper means easier expansion. Flatter means stiffness. That single picture solves a lot of stems. All right, hold the hook in your head. Easy inflation. Poor recoil. Why? Let's build from the core idea and work our way to the curve and the clinic. By the end of this session, you'll be able to do 6 things, exam style. First, define compliance clearly and tell apart lung compliance, chest wall compliance, and the combined respiratory system, plus the practical difference between static and dynamic measurements. Second, you'll read the pressure-volume curve with confidence and explain hysteresis in plain language. Third, you'll list the key determinants of compliance, tissue elasticity, the role of surfactant and surface tension, how lung volume changes the picture, and how the chest wall helps or hinders expansion. Fourth, you'll measure compliance at the bedside. Use the brief inspiratory pause for the settled, static view. Use the highest pressure during flow for the dynamic view, and interpret the relationship between peak and plateau pressures. Fifth, you'll map clinical patterns fast. High compliance with poor recoil in emphysema, low compliance in fibrosis, ARDS, and pulmonary edema, and how chest wall problems reduce chest wall compliance and shift the whole system. And sixth, we'll finish by solving 4 NEET PG-style MCQS to lock in these ideas. One exam alert before we move on: pressure-volume curves and their clinical correlations are high yield. When you see the curve, think slope, think recruitment, and you'll crack most stems in seconds. When I say compliance, think how easily it expands for a given push. High compliance means it opens up with little effort. Low compliance means it's stiff and needs a lot of pressure. There are 3 parts to remember: lung compliance, the stretchiness of the lung tissue itself; chest wall compliance, the give of the ribs, muscles, and diaphragm; respiratory system compliance, the 2 together. Because the lung and chest wall are linked in series, the combined value is always lower than either one alone. So if either gets stiffer, the overall number drops noticeably. 2 practical flavors you'll see everywhere: static compliance, measured when airflow has been paused briefly. This reflects the true elastic behavior of lungs plus chest wall, without the noise of air moving. On a ventilator, think of the pressure you read after an inspiratory hold. Dynamic compliance, measured while air is flowing. This is influenced by both tissue stretchiness and airway resistance. On a ventilator, think of the highest pressure reached during inspiration. Fast interpretation shortcut. If dynamic worsens but static is similar, suspect airway resistance, bronchospasm, secretions, a kinked tube. If both worsen, think stiff lungs or stiff chest wall, fibrosis, edema/ARDS, obesity, tight dressings, or abdominal distension. Keep one picture in mind for every exam stem. On the pressure-volume graph, a steeper region means easier expansion, and a flatter region means stiffness. This single idea will guide every decision and every multiple choice question that follows. Look at the graph on the right. The horizontal axis is the pressure across the lung. The vertical axis is lung volume. 3 anchor points matter in exams: RV near the bottom, FRC in the middle, and TLC near the top. Now, how do we read this curve? Near RV, the line is flat. Many alveoli are closed or sticky, so early pressure doesn't buy you much volume. Around FRC, the line becomes steep. Small pressure changes now give you big volume gains. This is where the lung is most compliant and happiest. Near TLC, the line flattens again. Fibers are tight, most units are already open, and extra pressure adds little volume. This is the overstretch zone. Key idea to say out loud: compliance is the slope of this line. Steeper means easier expansion. Flatter means stiffness. 2 quick habits. When you see a curve, locate FRC. That mid-range steep zone is where you want most breaths to live. If a question describes lungs that are hard to fill at low volumes or at very high volumes, picture those flat regions at the bottom and top of the curve. Exam alert. If you can translate a stem into flat versus steep on this picture, you'll usually get the answer right in seconds. Hysteresis. Inspiration is not the same as expiration. Look at the 2 lines on the graph. The blue line is the path during inspiration. The red line is the path during expiration. Notice they don't overlap. Together they form a loop. That difference is called hysteresis. Here's the key observation. For the same pressure, the expiratory path sits higher, which means the lung holds more volume on the way out than it did at the same pressure on the way in. Why does that happen? 2 reasons you should always remember. Surfactant dynamics. As the lung inflates, surfactant takes a moment and some stretch to spread effectively. Early in inspiration, surface tension is relatively higher, so you need more push to gain volume. Once spread, on the way out, surface tension is lower, so the lung keeps more volume at the same pressure. Alveolar recruitment. During inflation, some units are collapsed or sticky and open only after enough pressure. Think of them popping open. During deflation, those now open units tend to stay open longer, so you carry more volume for the same pressure. Why this matters clinically: recruitment maneuvers and PEEP use hysteresis to advantage. A brief rise in pressure opens stubborn alveoli. Then a modest PEEP helps keep them open at lower pressures along the expiratory path, improving gas exchange and reducing the work of breathing. Exam tip: if a question says after a recruitment maneuver, the patient maintains better volumes at lower pressures. Translate that directly to hysteresis. And whenever you see the loop, ask yourself, are we opening lung units and then preventing them from collapsing on the way back down? Lung, chest wall, and the combined system. Start with the 2 parts separately. Isolated lung. By its elastic nature, the lung wants to recoil inward. Even at the normal resting point, it's gently pulling in on itself. Isolated chest wall. The rib cage and diaphragm tend to spring outward at rest. Left alone, the chest wall would sit a little bigger than the lungs would like. Now put them together. At the everyday resting level, functional residual capacity, the inward pull of the lung and the outward spring of the chest wall balance each other. That's why, at rest with the glottis open and no muscular effort, there's no net pressure pushing air in or out. 2 take-home points. The combined system is less compliant than either part alone. When you link a structure that pulls in with one that springs out, the pair is harder to move than each by itself. If either component changes, the resting balance shifts. Stiffer lungs, as in fibrosis or pulmonary edema, pull the system towards smaller volumes. The resting point moves down. More compliant lungs, as in emphysema, reduce inward recoil. The resting point can drift up. Stiff chest wall, obesity, kyphoscoliosis, tight abdominal contents, blunts the outward spring and also shifts the resting point down. Exam shortcut. When a stem says, at rest, no airflow, patient relaxed, Think functional residual capacity. That's the equilibrium where inward lung recoil equals outward chest wall recoil. Changes in either side explain the new resting volume and the patient's work of breathing. Determinants. Tissue elastic properties. Start with the fabric of the lung. Elastin is the stretchy element that gives the lung its snap back. Collagen is the seatbelt that prevents overstretch. The ratio and arrangement of these two decide how compliant the lung will be. Next, think of alveolar interdependence. Alveoli are not isolated balloons. They're linked by connective tissue. When one unit opens, it helps its neighbors stay open. When one tends to collapse, the surrounding pull resists that collapse. This network effect stabilizes the lung and evens out expansion. Now aging. With age, elastin fibers thin and fray. The lung becomes more compliant. The resting volume creeps up, and passive expiration slows because recoil is weaker. Elderly lungs feel softer, but they don't empty as briskly. Contrast that with inflammation and fibrosis. Here, collagen is laid down and the interstitium thickens. Recoil rises, compliance drops, the work of breathing increases, and volumes fall. This is the stiff lung picture. Exam alert. Loss of elastic recoil can show up via different routes. Emphysema with tissue destruction, aging with elastin degradation, and alpha-1 antitrypsin deficiency with unchecked elastase damage. Mechanisms differ, but the clinical feel is similar. Easier to inflate, poorer recoil, and altered resting volumes. Keep that pattern in mind as we move to surface tension and surfactant. Determinants. Surface tension and Laplace's law. At the air-liquid lining of every alveolus, surface tension tries to make that bubble collapse. The smaller the bubble, the stronger that inward pull. So tiny alveoli are most at risk. Now, without surfactant, small alveoli would empty into larger ones and collapse. Surfactant fixes this. It spreads across the lining and cuts surface tension, especially well in small alveoli, so they don't implode. That's why surfactant stabilizes the lung. Big and small units can coexist without the little ones being sacrificed. There's also a volume story here. At very low volumes, many units are closed or sticky. Compliance is poor because you're spending energy on recruitment. At very high volumes, fibers are taut and units are already open. Extra pressure gives little extra volume. Think overdistension and falling compliance. In the middle range, with surfactant doing its job, the lung is most compliant. Clinical links to remember. Neonatal respiratory distress and severe ARDS often mean surfactant deficiency or dysfunction. Surface tension rises, compliance falls, ventilation becomes difficult. That's why exogenous surfactant helps in neonates, and why strategies that maintain end expiratory volume, like PEEP, can prevent repetitive collapse and reopening. Exam tip. When a stem says small alveoli tend to collapse into larger ones, translate that to high surface tension without effective surfactant. When it says better volumes at end expiration with PEEP, think stabilizing alveoli against that inward pull. Measurement at the bedside. Static versus dynamic. On a ventilator, we have two everyday snapshots. Static compliance is the no-flow snapshot. We give a breath and briefly hold it at the end of inspiration. During that pause, airflow stops and the pressure settles to the plateau pressure. That value reflects the true elastic behavior of lungs plus chest wall. No contribution from moving air. Use this number to judge stiffness. Dynamic compliance is the in-motion snapshot. Here we look at the peak pressure while air is still flowing. This includes both the elastic load and the extra pressure needed to push air through the airways, so it's influenced by airway resistance. Because of that, dynamic compliance is always lower than static compliance. How to read them together. If peak pressure rises but plateau stays the same, think resistance problem, bronchospasm, secretions, water in the circuit, or a kinked/bitten tube. If both peak and plateau rise in parallel, Think true stiffness, pulmonary edema, ARDS, fibrosis, a tight chest wall, obesity, or abdominal distension. Waveform reminder. On the pressure time graph, the taller first plateau is peak. The settled second step is plateau. The gap between peak and plateau is the resistive component. Bigger gap means higher airway resistance. Practical anchors. Plateau pressure reflects elastic properties, the real compliance. The difference between peak and plateau reflects airway resistance. Typical static compliance in an adult ventilated lung sits roughly in the 50 to 100 milliliters per centimeter of water range. Lower values mean a stiffer system. Exam alert. A stem that says peak pressure has increased but plateau is unchanged is pointing to increased airway resistance, not a fall in compliance. Clinical pattern: increased compliance, emphysema. On the left is a normal pressure-volume curve, a steady rise with balanced elastic recoil and a comfortable resting point. Now look at emphysema on the right. The curve becomes steeper in the middle, meaning the lungs inflate easily, but the top flattens because recoil is poor. The resting volume shifts upward, so patients live at a higher end expiratory volume. Think hyperinflation. Why does this happen? Destruction of alveolar walls and loss of the elastic network. With weaker tethering, small airways collapse early during exhalation. So although air goes in easily, it can't get out efficiently. Clinical consequences: air trapping and dynamic hyperinflation. Breaths stack on top of each other. Development of auto-PEEP. The patient starts the next breath before fully exhaling. Over time, a barrel chest and a diaphragm pushed flat, which worsens mechanics. Exam takeaway: emphysema means high compliance, low recoil, resting volume. The paradox is key: easier inflation but expiratory flow limitation from airway collapse. When you see a stem with easy to inflate plus prolonged expiration, hyperinflation, or auto-PEEP, your answer lives on this emphysema curve. Clinical pattern: decreased compliance, fibrosis, ARDS, edema. On the left is normal, a comfortably steep mid-segment of the pressure-volume curve. Moderate pressure gives a good volume change. On the right, with decreased compliance, the curve is flatter. These lungs are stiff. You have to push harder to get the same tidal volume, and the resting volume often sits lower. Think in two buckets. Parenchymal causes pulmonary fibrosis, collagen deposition, and scarring. Classic stiff lung. ARDS, inflammation, fluid, and surfactant dysfunction. Units collapse and reopen, making the lung heavy and non-compliant. Pulmonary edema, fluid-filled alveoli reduce stretch. Pneumonia, consolidation and exudate stiffen regions of lung. Chest wall causes, reduced chest wall compliance. Obesity or tense abdomen pushes the diaphragm up, limiting expansion. Late pregnancy, similar diaphragmatic elevation. Kyphoscoliosis, abnormal spine curvature restricts mechanics. Burns/contractures or tight dressings. External restriction. Bedside implications. Expect higher airway pressures for a given tidal volume. Use lung protective ventilation. Lower tidal volumes and appropriate PEEP to avoid overdistension of the remaining open units. If pressures rise in parallel and the curve looks uniformly flat, think true stiffness rather than an airway resistance problem. Exam takeaway: stiff lung or stiff chest wall equals flatter curve, more pressure, lower resting volume. Manage with protective settings and careful recruitment, not big breaths. Rapid recap: high yield in 1 minute. Compliance is how easily volume rises for a given push. On the PV curve, steeper slope means higher compliance. A flat line means stiffness. Whole system compliance comes from lung plus chest wall working together, and the combined value is always lower than either one alone. If the lung or the chest wall gets stiffer, the overall number drops. Hysteresis: the inspiratory path and expiratory path don't match. Thanks to surfactant spread and recruitment, The lung holds more volume on the way out at the same pressure. Static versus dynamic. Static is the no flow, plateau snapshot, true stretchiness. Dynamic is the inflow peak snapshot, stretchiness plus airway resistance. If peak rises but plateau doesn't, think bronchospasm secretions. If both rise, think stiff lungs or stiff chest wall. Patterns you must recognize. Emphysema, higher compliance, poor recoil, higher resting volume. Fibrosis/ARDS/edema, lower compliance, higher pressures needed. Chest wall problems, obesity, kyphoscoliosis, tight abdomen, reduced chest wall compliance, lowering the combined system. Exam alert. Most stems are cracked by 2 moves. Decide static versus dynamic and read the steep versus flat part of the PV curve. MCQ 1, static versus dynamic compliance. A ventilated patient has a tidal volume of 450 milliliters, PEEP 5, peak pressure 40, and plateau pressure 20. What's most likely? Start by comparing peak and plateau. There's a big gap between them. Remember, plateau reflects the elastic load, the true stretchiness of lungs plus chest wall. Peak includes elastic load plus airway resistance. When the gap widens but the plateau itself isn't very high, the problem is airway resistance, not stiffness. That fits bronchospasm, secretions, kinks, water in the circuit, not reduced static compliance. Now eliminate. Reduce static compliance only, would push plateau up as well. Not the case. Auto PEEP with normal resistance. You'd expect clues like incomplete exhalation or rising end expiratory flow. The key finding here is the large peak-plateau gap. Circuit leak usually shows low delivered volumes and trouble holding pressure, not a large gap. Answer B. Increased airway resistance. The large difference between peak and plateau points to resistance in the airways while overall elastic properties are near normal. MCQ 2, disease, curve pattern. Question. Which condition shows a steeper pressure volume slope and a higher resting volume than normal? Work it out from the curve logic. Emphysema. Elastic tissue is lost, so the lung becomes easy to inflate. Steeper mid-curve, higher compliance. Inward recoil is weak, so the resting volume drifts up. Higher FRC. Fibrosis and ARDS. Lungs are stiff, flatter slope and usually lower resting volume. Pneumonia. Consolidated segments behave stiffly. Again flatter, not steeper. Answer C. Emphysema. Key line to give students. Easy to get air in, hard to get air out, steeper curve and higher FRC due to poor recoil, which also explains hyperinflation and the barrel chest tendency. During volume-controlled ventilation, the peak pressure rises from 30 to 45, but plateau stays 22. Tidal volume and PEEP are unchanged. What does that mean? Remember the rule. Plateau equals elastic load. Peak equals elastic load plus airway resistance. When peak goes up while plateau is stable, the extra pressure is being spent pushing through narrow airways, not stretching a stiffer lung. So the best answer is mucus plugging or bronchospasm. Quick eliminations. Worsening fibrosis or decreased chest wall compliance would raise plateau as well. Pneumothorax usually increases the elastic load or causes sudden ventilator alarms and instability. Again, you'd expect a change in plateau. Bedside next steps. Suction for secretions. Check for kinks/water in the circuit. Increase expiratory time, and give bronchodilator if obstructive physiology is suspected. MCQ 4, hysteresis and surfactant statement. For a given transpulmonary pressure, expiratory volume exceeds inspiratory volume due to surfactant recruitment and alveolar stability. This is true. Here's the logic in one breath. During inspiration, surfactant needs stretch and time to spread, so early surface tension is relatively higher and you pay more pressure for volume. Once units open and surfactant is well distributed, the lung deflates along a friendlier path. Surfactant molecules become relatively more concentrated, surface tension is lower, and the alveoli stay open longer. Result: at the same pressure, the expiratory limb sits above the inspiratory limb. Classic hysteresis. Clinical pearl to end. This is why a brief recruitment step plus appropriate PEEP can maintain better volumes at lower pressures. Open with a push, keep open with support. That wraps up our session on compliance of the lungs and chest wall. Big takeaways to carry into your NEET PG prep. Think in pictures. On the PV curve, steep equals easy to expand, flat equals stiffness. Separate static, true stretchiness, from dynamic, stretchiness plus resistance. Map patterns fast, emphysema, high compliance, poor recoil, higher resting volume, fibrosis/ARDS/edema, low compliance, higher pressures needed, chest wall restriction lowers the whole system's give. Hysteresis explains why recruitment then PEEP helps. Open stubborn units, then keep them open. Thank you for your attention.